Having done our assessment very well, we've done our assessment, the first step in perioperative nursing care, we are going to move over to nursing diagnosis. Nursing diagnosis. From this pertinent data we collected from the patients, we are going to cluster them together, and from this we now form our nursing diagnosis. And nursing diagnosis, preoperative nursing diagnosis are made based on disease condition of the patient, the chief complaints that the patient told you, the review of system and relevant records and data you reviewed. From all this, you ask the patient the history that the patient gave you, the chief complaints, what brought the patient to the hospital, the review of the system, the review of relevant records and data, even diagnostic investigation. From them, you now cluster to know what is wrong with the patient. By the time you use it, you now form what we call nursing diagnosis. And general preoperative nursing diagnosis we normally have for our patients, notwithstanding the condition of the patient. Because if somebody came to the hospital with hypertension, with diabetes, their preoperative nursing care will not be the same, because the conditions are not the same. The patient did not have the same symptom or the same sign. But for generally, a patient that is going for surgery, for the preoperative nursing care of that patient, number one, we have knowledge deficit. Number one diagnosis is knowledge deficient. Knowledge deficient simply means that the patient lacks understanding or knowledge or what to expect during the surgery. The pre and post-operative expectation, patient does not know what is happening. So it's now the nurse that will teach the patient, explain to the patient, inform the patient what to expect during, before, and after the surgery. Number two diagnosis we normally make for general patient that is going for surgery is anxiety. Anxiety due to unknown outcome of surgery. Patient does not know whether he will die in the theater, whether the surgery will be successful or whether the surgery will not be successful, whether there will be complication. So all this causes anxiety in the patient, and the nurse should intervene. Some people have not been to the hospital before, and you have admitted them to do a surgery. So even the fear of unfamiliar environment is even causing the anxiety to the patients. Number three is insomnia. Insomnia simply means inability of the patient to fall asleep. A patient that is preparing for surgery the next day normally finds it difficult to sleep because of so many questions, because of fear, because of not knowing what to expect. So the nurse has to intervene in area of insomnia. Some might have insomnia due to unfamiliar environment. It's not every person that sleeps in another person's house, let alone the hospital. Or even pain can cause the patient not to fall asleep. The fourth area we have to diagnose the patient is in area of nutrition or fluid. Number four, nutrition / fluid imbalance. Nutrition fluid imbalance simply means that it's less than body requirements because there are some restrictions that patient needs to make before the surgery. Like 8 hours before surgery, patient does not eat anything orally. So the nurse needs to do something in order to augment when the patient is not eating anything orally. The fifth area is self-care deficit. Self-care deficit. There are so many things to do, so many preparations to make for the surgery, and patient might not have the knowledge or the will or the power to do all these things. It's the nurse that will prepare the patient and be able to provide self-care needs of the patient for the surgery. Number 6 is elimination impaired. Elimination impaired, it could be in form of urinary or bowel impairment. Elimination. Elimination impaired, which may be in form of urinary or bowel. These are the 6 areas, general 6 areas, irrespective of the condition of the patient, that a diagnosis may be made in a patient that is going for surgery. We say knowledge deficient. There are some things to expect that patient does not know. Is the nurse that will teach the patient what to expect, when this and this will be done, what is coming next and what is not. Anxiety because of unfamiliar environment, or no outcome. Patient does not know whether he will die, whether he will make it, whether there will be complication. So patient is anxious. Insomnia, inability to fall asleep because of the impending surgery. Nutrition, because we have some restrictions. Patients will not eat for some time before going to surgery. So you have to intervene in area of nutrition. Self-care, preparing the patient, grooming the patient. Elimination. Sometimes we need something like catheterization, something like preparing the bowel. That's why we are making this diagnosis in elimination impaired. Establish our nursing diagnosis for the patient that is going for surgery. These are the pre-operative nursing diagnosis. The next thing we are going to do is to set objectives. Objective means interval that is going to take for us to solve these problems of the patient. In knowledge deficit, anxiety, insomnia, nutrition, self-care, anything that is not CAB, circulation, airway, breathing, you can set long-term objectives. But for CAB, in circulation and airway, if you set long-term objectives, that is not short. Short objectives is something you achieve within 15 minutes to 30 minutes or latest an hour. If patient is having problem with circulation, with airway, with breathing, your objective should be within 30 minutes, within 45 minutes or an hour. That situation is solved, is resolved. But something like knowledge deficit, anxiety, insomnia, nutrition, we may have long-term objective. We can say that within 5 minutes, patient will know everything that we're going to explain. That's what we mean by setting long-term objective and short-term objective. So all this one requires long-term objective, maybe within 24 hours, 48 hours, this thing will be solved. Or latest 8 hours, at least 8 hours or 7 hours, these things will be resolved. But if it were to be emergency side, CAB, within 30 minutes, within 45 minutes, within 15 minutes, you have achieved the objective, the goal. Then planning means certain instruments, certain whatever you need to do, organizing it, bringing them out, whatever that you need to solve the problem of the patient, you get it in place. Then implementation. Implementation simply means doing something to relieve this knowledge deficit so that patients will have knowledge about what is happening. And in solving knowledge deficiency, there are interventions the nurse needs to do in order to solve the problem of the patient. First, you have to verify what the physician has explained to the patient concerning the surgery. It's not the duty of the nurse to tell the patient what will happen in theater or the extent of the surgery. All you need to do is to verify what the physician, what the surgeon has told the patient about the surgery, impending surgery. If they have explained to the patient what they are doing, let the patient tell you what they say so that you make sure that patient has concrete explanation or full explanation of what is going to be done. It is on this note that you have to obtain informed consent and witness it. If patient does not tell you what they are going to do, inform the physician to come and explain to the patient before you witness a consent. Then verify whether the patient has completed all the preoperative tests that is prescribed for the patient. Verify also whether the patient understands some other specific orders like bowel preparation, insertion of indwelling catheter. If patient has not understood them, you have to explain all these things. In relieving the patient, solving this knowledge deficiency of the patient, you have to explain to the patient the phases of operative nursing care. Explain the pre-operative care, what is involved, the intra-operative care, what the patient is to see in the theater, what to expect, then explain the post-operative expectations so that patient will have knowledge of every bit of what he or her is going to pass through. Initiate teaching appropriately. Before you start teaching the patient, note if that patient will be able to assimilate what we are going to teach. If patient is upset, if patient is not in the mood, wait. Relax the patient until the patient is able to assimilate what you are going to take. Then teach the patient what we call incentive spirometry, deep breathing exercise, leg and hand exercise. All these things we teach the patient side by side turning, coughing. Because by the time patient will have the surgery, the pain will be too much, patient will not listen, will not learn this. It is in pre-operative teaching that will tell the patient all these things. Then anxiety, coming to anxiety, patient that comes to hospital, familiar environment is very anxious. Is not in line with hospital routines, so you have to create rapport with the patient. What do we mean by creating rapport with the patient? You smile with the patient, you talk to them calmly, you respect them. If you don't respect them, when you need something from them, they themselves will pay you with your own coin. So you have to smile, you have to relax with them, you have to use therapeutic relationship. Ask the patient questions to know what fears and concerns the patient have about the surgery. Show empathy. Give a listening ear. Don't be nonchalant. If you are nonchalant, patient's anxiety level will be much. Determine patient readiness to understand whatever you are telling the patient. Provide information and answers accurately. Don't establish falsehood. Provide quiet environments. Diversional therapy like playing music, playing Lido, reading newspaper, encourage visits so that patient will calm down. If there are prescribed anxiolytics like diazepam and metriptyline, you give the patient to calm the patient down. Insomnia, area of insomnia, inability to fall asleep, the patient cannot sleep, maybe because of the surgery, because of unfamiliar environment, the noise in the hospital. You assess hours patient normally sleep, the previous pattern sleep of the patient. Is it that the patient sleep up to 4-5 hours or not? Ensure that patient sleeps in the night before surgery by making the environment conducive. Give a warm bath. Provide cold beverages. Provide diversional therapy. Make the patient comfort by making sure that the foams, the mattress, the bed linen, they are okay. Then, if the patient has pain, we treat pain, because pain at times will cause the patient not to sleep. Then discourage the patient from having a nap during the day, because it will diminish the sleeping time of the patient, and this will affect the surgery. So give prescribed medication. About insomnia, nutrition or fluid imbalance. This area we are making sure that patients get fluid and adequate nutrition. Because if patient does not get adequate fluid and nutrition, wound healing might be delayed. So we ensure that we are serving adequate diets and patient is taking enough water, 1.5 to 3 liters a day, if an adult, if condition is not contraindicated. Then we maintain what we call NIPE oral. From 8 hours before surgery, patient does not take anything orally, so that there will be no aspiration during anesthetic period. And what we normally do is we have a small clip placed on patient bedside, and we write NIPE oral placed at the patient bed, so that patients will be always be reminded that he is not supposed to eat anything, and whoever that comes to patient bedside will not serve any meal or serve any medication. within 8 hours of surgery. So when the patient is restricted from taking things orally, they might set intravenous infusion. So you make sure that the intravenous infusion is flowing at the required rate, and you keep intake and output charts. Give oral mouth-care, mouthwash, oral toileting, but tell the patient not to swallow any fluid while doing oral care. Notify surgeon in case the patient has taken anything orally, so that they know what to do, whether to cancel the surgery or whether to pass NG tube to aspirate the stomach content before the surgery. Share specific order for insertion of NG tube or administration of medication before surgery, and adhere strictly to any order. Okay. Self-care deficit. Why we brought self-care deficit is at times patient will be too weak to bath himself. It is the duty of the nurse to make sure that patient takes a bath in the night, in the morning of the surgery. You do oral toileting, you do oral care. That's what we mean. Grooming, dress the patient properly, change the patient's nightgown, put on theater gown on the patient. Patient does not go to theater with normal nightgown, but rather put on cap, theater caps. All this comes under self-care deficit. Eliminations or impaired. Sometimes a type of surgery that patient is going through might require that you pass urinary catheter, indwelling urinary catheter. If that is the case, you pass the indwelling urinary catheter. If patient requires enema, it is the duty of the nurse to do enema in the night and in the morning of the surgery, so that the surgeons will have a clean field to work with. We are moving over to intraoperative nursing care. Intraoperative nursing care. Self-care deficit simply means activities the patient would have done for him or herself, but because of lack of knowledge, lack of willpower, or because of anxiety or whatnot, the patient cannot do it. And it's in area of hygiene, skin preparation, and special orders. The patients must surely take baths in the night and in the morning of surgery, and it's the duty of the nurse to make sure that patient takes a bath. Then oral toileting, mouthwash, and grooming. You dress the patient very well, remove the nightgown or the pajamas, put on theater clothes on the patient. Shaving is done, or if it is not done, this is done immediately surgery patient comes to operating theater. The surgeons might do that, but the one that concerns the nurse, importantly, if there are females, make sure that they don't have any nail polish, could test, because if they have it, it is difficult for the surgeons or the anesthetist to assess the circulatory status of the patient. So you have to remove every nail polish, every lipstick, make sure that even powder. Patient should be as plain as possible so that he or she will be assessed. Dress patient in theater gown, theater caps, we've said it. Remove all artificial things that patient is putting on, the wig, the eyelashes, the prosthesis, the dentures, whatever artificial the patient has. Artificial limb is removed, even contact lens and eyelashes. We've said that. If patient has something like implants or something that has to do with legs, like a cardiac patient, you have to tell the surgeon. Notify operating theater of if patient is using, that's what we mean, if the patient has hearing aids, any hearing aids that has legs or pacemakers, so that they know what precautions that they should take. Before, we've talked about elimination, passing of urinary catheter, passing of enema washout, enema to be returned, so that surgeons, if the operation is in the urinary area, the surgeons will have a good field to work with. So we're moving over to intraoperative nursing diagnosis. Intraoperative nursing care. Intraoperative nursing care, we say that intraoperative nursing care is majorly from the time patient is removed from operating theater to the post-anesthetic unit. The nurses in the ward, they don't know much about it because it's the recovery room nurse, the anesthetist that takes care of the patient. But what they normally do in this post-operative nursing care is to assess the patient, to make sure that pain is managed, management of pain. Any risk from the surgery, they control risk so that patient, during positioning of the patient, even the anesthetic drug the patient you are giving, patient does not incur any risk from that. You know that patient that comes from theater is still confused. There is still disturbed sensory perception. So patient does not know where he or she is still coming back from the effect of anesthesia. So it's in intraoperative nursing care that they do all this by calling the person's name, telling him or her that surgery is over, you are in recovery room, you need to get back to the ward, are you all right? All this they are making is to make sure that patient is alive, patient is normal, and patient is coming back from effect of anesthesia, so that patient will recover and they send him or her back to the ward. Nursing care in recovery room, in monitoring of vital signs every quarter hourly, using of pulse oximetry to monitor the oxygen concentration in the blood, TPR, pain, skin color, loss of level of consciousness of the patient. We also monitor the surgical site to make sure that patient is not bleeding, there is no hemorrhage. All the drainage tubes, they are connected, all the IV lines, they are connected, and we harass the patient every moment so that patient will recover and get back to the ward. So immediate post-operative nursing care of the patient. When the patient recovers in the recovery room, they will now send message to the ward, the particular ward from which patient came to theater, to come and take the patient. And when you are going to theater to take over your patients, immediately you come to the recovery room or post-anesthetic care units, call your patient by name to ascertain the level of consciousness of the patient. Check pulse immediately to make sure that your patient is breathing, that your patient is alive. Some people have taken over a dead patient because of carelessness. Before you take over your patient, call the patient, make sure patient is recovering, make sure the patient has pulse, then you collect the patient. So we are going over to immediate post-operative nursing diagnosis of this patient that we received from theater. Basically, patient has number one, tissue perfusion ineffective. Tissue perfusion ineffective. Patient might have this diagnosis. It's all about effect of anesthesia, effect of hemorrhage. If patient lost so much blood in the theater, patient might be having weak pulse. Patient might, the circulatory blood will not be enough, so patient will show signs of shock. If patient is showing signs of shock, automatically you make a diagnosis of tissue perfusion ineffective peripheral. And there are things you have to do to solve it. You assess vital signs and you document. You administer IV fluid, intravenous fluid, whatever the one that is prescribed for the patient, you administer it. If patient is to receive blood transfusion, because he has not received in the theater, you have to monitor the blood transfusion or any blood products. Manage pain. Pain can cause the patient to go into shock. You assess the level of pain and give that any post-operative analgesic prescribed for the patient. Avoid exposure. Cover the patient lightly with blanket. Too much cold will make the patient's condition worse because of vasodilation. You position the patient flat on the bed with legs elevated. That is, use pillow to elevate the legs of the foot of the patient so that enough blood will be getting into the head so the patient will not die until, okay. Having come to the recovery room, we collected our patient to the ward. The next line of management is post-operative nursing care. Post-operative nursing care of the patient. Basically, we have number one diagnosis, tissue perfusion. Post-operative nursing care diagnosis. The first diagnosis we are going to look at is tissue perfusion. Tissue perfusion, ineffective. This is a diagnosis made for a patient that came back from theater and is having signs and symptoms of shock because of loss of blood, loss of fluid. So what the nurse will do is to assess the vital signs and document, administer IV fluid that is prescribed for the patient at the prescribed rate. If the patient is to receive blood transfusion, you monitor the blood transfusion and document. Manage pain effectively, because pain can cause the patient to go into shock. Avoid exposure of the patient to prevent vasodilation. Then the position you will nurse the patient is you raise the foot of the bed with pillow so that enough oxygen will be getting to the brain. Administer prescribed medications to elevate BP. Then you monitor vital signs judiciously, quarter-hourly. If patient condition is getting worse and the tissue perfusion is not resolving, you start oxygen. Give oxygen administration as prescribed. The next line of management is airway clearance. Airway clearance. Airway clearance, ineffective. We are making this diagnosis because patients that came back from theater, because of effects of anesthesia, they are not able to cough out secretions in the airway. You see sometimes mucus block their tongues, block their mouths. So it's the duty of the nurse that make sure that the patient airway is cleared. How do you clear the airway? You assess SpO2, respiratory rates, depth, and breath sound. This will give you indication whether patient's airway is obstructed with mucus. You nurse the patient with head turned to one side. Patient head must be turned to one side so that those secretions will be draining out. If they are not draining out, patient will aspirate fluid into the lungs and it will be a problem. Turn patient's head to one side. If patient teeth is clenched, use padded spatula to open the mouth so that, or you use tongue depressor to open the mouth so that secretions will be going out. If the patient's airway is seriously obstructed, you can use endotracheal tube or use pharyngeal airway to make sure that the patient airway is open. You give prescribed oxygen therapy, give prescribed fluid, because fluid will liquefy those secretions and then all of them will be coming out through the mouth. Provide chest physiotherapy or postural drainage so that those secretions will be mopped up and the patient, it will come out from the patient's mouth. Maintain nipple oral. Don't give patient anything by orally until reflexes are returned. Maybe coughing and swallowing reflexes. The third diagnosis for post-operative patients is breathing pattern ineffective. Breathing pattern. Breathing pattern. Ineffective. This simply means that patient is not breathing well. Maybe patient is finding it difficult to take in air into the lungs. You assess respiratory function, you assess breath sound, assess the skin color of the patient, including sp2. Remove every tight clothing that is around the chest of the patient so that the lungs will be expanding. Open nearby doors and windows, switch on fan. Encourage the patient to do that deep breathing and coughing exercise that you taught him or her during the preoperative period. Do chest physiotherapy, sanction the patient necessarily, and turn patient periodically so that the lungs will expand. You encourage the patient to do incentive spirometry and give oxygen. In management of pain, the fourth one is pain. Fourth one is pain. We normally say pain maybe 4/5 or 3/5. Every patient that has gone surgery normally come back with pain because there are incisions. It's the duty of the nurse to manage pain effectively by help the patient to assume a position of comfort, provide comfort measure like massaging the patient, relaxation techniques like using deep breathing exercise, television, story, giving the patient newspaper to read. Then encourage conducive environment, give prescribed opioid. Opioids are normally written for the patient, pentazocine or whatever. Don't say patient is not complaining or is not asking. Always give it as prescribed so that pain will not cause patients to go into shock. Other post-operative nursing care diagnoses might be nutrition imbalance, self-care deficit, infection risk 4, body image disturbed, fluid volume deficit. These are probabilities, probable areas you have to make diagnosis if need be. In wound care, you have to ensure aseptic technique. Assess that the wound is dry. If it's not dry, tell the doctors immediately report. Then in area of advice on discharge, tell patients to adhere to home drugs, maintain hygiene, personal environmental hygiene, avoid smoking, rest and sleep, even avoid strenuous exercise, and always come for his or her follow-up. Complications that follow surgery may be in form of respiratory obstruction, form of shock, hemorrhage, vomiting, and infection. By this, we've come to the end of this topic on introduction to operative nursing care.